Read out the stem, Dr. Prabhat.
Okay, sir. 45 years old lady presented by hypotension and tachycardia in post-operative uh, total hip replacement or Hartmann procedure. She has been transferred to the ward at 3 p.m. and she was found with BP of 70 by 30 and tachycardia at 2 a.m. on the fluid side. And on the fluid side, she has given 2 into 250 ml bolus infusion.
Your voice
She
is
was
slow,
given.
Dr. Prabhat.
My voice is
Okay,
low. Okay, wait.
all right. So, can you explain the fluid chart?
Okay, so um, uh, uh, there is a persistent hypertension, and only the two fluid challenge is given.
So, is that
So
adequate?
no, it is not adequate.
Okay. How will you manage this patient? Okay,
So
we will
first,
come back. We will come back to the management part later. First, tell me,
okay,
what is the
okay,
formula of fluid challenge?
okay. So for the fluid challenge, the fluid is 250 to 500 ml in 15 to 30 minutes.
Okay, now how will you
Twister
manage
blades.
this in this case?
So I will first I will manage the patient according to the care of critical ill surgical patient protocol following ABCD. And for the fluids, I will initiate more of the fluid challenge and see if he is tolerating, if he is improving or not.
Okay, so
If she is
all
improving.
right. Now, why would you give fluid challenge rather than speeding up the drip like?
Um, Actually, we can give up to 3 to 4 foot fluid challenge, and if she is not improving, then we can shift into infusion.
Now, I'm asking you, why would you give fluid challenge rather than speeding up the drip?
Okay, so I will come back to this question
Okay, you
later.
will come back to this question. All right. The patient is on 2 hours monitoring. Is that adequate?
No, sir, we need to do hourly monitoring.
Okay. Who to notify and when?
So I will notify my consultant, ID registrar, and anesthesiologist if there is no any improvement after the fluid challenge for around 2 to 3 times.
Okay. Now, suppose you will give him how many fluid challenge?
Uh, Three, sir.
Three or more than three. Okay. Then you will notify your
Okay.
consultant. Now,
Okay.
tell me, can you explain the Frank Starling law?
Yes, sir. Uh, in heart, if there is increase in diastolic pressure, in diastolic volume, there will be more stretching of the muscles and there will be more of cardiac output. So basically, if there is increase in the more stretching, the more the output will be.
All right. So the greater the left ventricular diastolic volume, what you have mentioned, the greater will be the stretch during diastole, and
Yes.
there will be fibers are stretched, and the greater the tension, and that will lead to the greater force of contraction. Correct. So according to the
Yes.
Frank Starling law, if you increase the fluid return to the heart, it will lead to increased cardiac output and increased stroke volume. All right.
Oh,
Now tell me,
oh, that's right.
how will you manage this
Yes.
patient after the fluid challenge?
Okay. So after the fluid challenge, first I would like to check the patient's cardiac index if the blood pressure, heart rate, and urinary output is improved or not. If it is not improved, then I'd like to liaise with multidisciplinary team and give IV saline of IV saline 1 liter in 1 hour.
So you will regularly review the clinical signs what you have mentioned, the capillary refill time, the cardiac index, which include the heart rate, blood pressure, capillary refill time. Then you
Yes.
will repeat the fluid challenge if necessary. Correct? You will consider the
Yes, sir.
possibility of internal or occult hemorrhage if the patient is still required fluid challenge, and we will leave the
Mm.
instruction for the nursing staff to contact you if they are concerned, correct?
Yes, sir.
Now, assuming the patient becomes more hemodynamically unstable and you have given more fluid challenges, now how to assess the cardiovascular function and the patient response to therapy?
Mm. So I will proceed with the invasive monitoring, like opening arterial line, and also doing a transesophageal Doppler if there is any deformity. And
Okay,
also, I would like to insert a central venous line and monitor CBP regularly.
very good, excellent. How the blood pressure is calculated?
So, blood pressure is the product of cardiac output and systemic vascular resistance, and cardiac output is heart rate and stroke volume.
Now, and stroke volume is,
Stroke volume is in diastolic volume. I will get back to this question
yeah,
later.
you are right. And diastolic volume minus what?
Minus ejection fraction. Minus
Minus
ejected
and systolic volume. Okay.
in system. Yeah.
Remember this. These are the recalls that we are discussing. Okay. So
Yes, sir.
how to increase the blood pressure?
So yes, I can increase. Uh, mm, yes, sir. I can increase the heart rate with inotropic or chronotropic support, and also increase systemic vascular resistance with vasopressors, and increase the heart rate, increase
And
the blood pressure.
okay, and you can increase the
Fluid,
fluid.
fluid
Yeah,
also.
you can increase the volume
Mm,
of the blood
mm.
by giving him the fluid. Now, tell me, what is the hormonal response to surgery and trauma?
Okay, so the hormone that are increased cortisol and catecholamine, growth hormone and glucagon and aldosterone and ADS, and the hormone that are decreased are insulin and sex hormones, and the hormone that are not changed is TSH and FSH, LH.
And LH. Okay. What are the mechanism by which the kidney increase the osmolarity in the renal medulla?
Okay, so basically there is a, counter current mechanism in which uh, 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 urine concentrates, kidney concentrate urine along a very short distance with a minimal expenditure of energy, which occurs in the loop of Henle.
Okay. So there are two questions. Okay. How medullary interstitium become hyperosmolar? The answer is counter
Yes, sir.
current multiplier mechanism. Okay, this is the single line one answer. Counter current multiplier mechanism. How the medullary
Okay.
interstitium hyperosmolarity is maintained by counter current exchanger was
By
erecta. Remember?
co-exchanger, yes, sir. By
Yeah,
reabsorbing water and solute
yeah.
water from
Now,
the descending plate and
all
solute
right.
from the ascending.
Why we call it counter current multiplier?
Yes, sir.
Yeah, these are the new question. All right.
Uh,
So,
okay.
cause it
Yeah.
work in opposite direction and multiply the osmolarity. That's why we call it counter current multiplier. Okay.
Okay, sir.
Okay. These three were the new question. Now, tell me what is the process by which the medullary tissue becomes hypertonic?
Process counter current mechanism.
Yeah, the counter current multiplier mechanism.
Okay, so is first of all the uh, should I explain or
Yeah, yeah, explain because I'm asking you what is the process.
okay, so first of all, there is a around a 30 osmolarity in the both interstitium and descending tract. And first of all, there is the solutes are reabsorbed to the interstitium, causing the hyperosmolarity, which in turns activates the water reabsorption from the descending tract. So this cycle repeats, and the osmolarity is increased from 300 to around 1200, which is at the end of the loop of the Henle.
Okay. So we will come back to this question. All right. Now to save your time.
Okay.
Okay. So where is ADH produced and what is the factor stimulating its secretion?
Okay, ADS is produced in hypothalamus, and the factors that stimulate is decreased blood volume, decreased osmolarity, no, hyperosmolarity, and angiotensin by stimulation of angiotensin 2
So you mentioned that ADH is produced in the hypothalamus, then it is transported and stored where?
in neurohypophysis, posterior pituitary.
Very good. Now tell me, where in the kidney does ADH act?
It acts in collecting duct and collecting duct. Is
Okay.
collecting duct.
All right. Very good. Okay. Now, why does the water cross from tubular fluid into the medulla?
Uh, because of increase osmolarity in the medullary interstitium due to countercurrent multiplier.
Okay. So it is because of the increased osmotic gradient between the tubular fluid and the medullary tissue. Now tell me what is the mechanism of action of antidiuretic hormone? It's a very important question.
Yes, sir. Antidiuretic hormone are mainly the drugs acting in PCT is carbonic anhydrase inhibitors, and in ascending loop of Henry there are loop diuretics which inhibits the sodium, potassium, and 2 chloride channel,
Wait a minute,
and
Dr. Prabhat, I'm asking you what is the mechanism of action of antidiuretic hormone?
oh, antidiuretic hormone. Sorry. Okay, so so antidiuretic hormone causes the um, inserts the aquaporin in collecting duct, which helps in the sodium solute free reabsorption of water from the urine.
Excellent, very good. Now, if the ADH is under the influence of angiotensin 2,
Yes,
it will
sir.
reabsorb the solute free water, correct?
No, sir. Under influence, it will absorb solute with solute, water with solute.
Remember, okay, Dr. Prabhat, if ADH is stimulated under the influence of aldosterone, it will cause the
Yes, sir.
absorption of sodium along with the water.
Yes, sir.
Now, if the ADH is stimulated under the effect of angiotensin 2, it will cause the reabsorption of solute free water. And they will ask you why, because of the aquaporin 1, 2, 3, 4 channel. In general, type 2 and 3 work for ADH, but under the influence of aldosterone, type 4 aquaporin channel work. That's why sodium in water will reabsorb. Okay. Remember the
Okay.
ADH function very well. Which type of aquaporins it will form? 1, 2, 3, 4. Okay.
Yes, sir.
Now, what is the
And
mechanism like? How does the aldosterone act on maintain the circulating volume?
okay, first of all, aldosterone acts on the principal cells in collecting duct, in which it causes the sodium and water reabsorption from the urine, increasing the uh, intravascular volume of the blood.
So, very good. The aldosterone, the side of the action of aldosterone, where it will act.
In distal convolutional tubule and collecting tubule.
Excellent, very good. What are the action of the renin-angiotensin aldosterone system?
Okay, so renin-angiotensin aldosterone system releases the angiotensin 2 enzyme to angiotensin 2 product, and it further activates the sympathetic plexus and causes the increased heart rate and increased blood pressure. It also activates aldosterone and leading to sodium water retention and potassium and hydrogen excretion, and also it stimulates ADH, which reabsorbs water from the urine, and also vasospasm in peripheral arteries.
So when there is decreased blood flow to the kidney will release
Yes.
renin from the JG apparatus, correct?
Yes, sir.
Now the renin will stimulate the production of angiotensin 1 from angiotensinogen. The angiotensin 1 will convert into angiotensin 2 from the ACE, angiotensin converting enzyme by the lung, correct?
Yes, sir.
Now, after this, first angiotensin 2 will stimulate aldosterone secretion from the kidney, and this will retain the sodium and water. It also causes the arterial vasoconstriction and the increased systemic vascular resistance, correct?
So we need to explain all those
You need to
procedures.
know each and everything about the RAS system. Remember this very well, okay? Because if they are going to ask you about fluid management, they will ask you about the diuretics, they will ask you about the RAS system, they will ask you the medullary interstitium, hyperosmolarity. These are the new question, okay? This medullary interstitium hyperosmolarity. So they are going to ask these 2 3 questions in the like these are they are asking this in the recent exams. So now tell me, you must know about each and everything about the RAS system, okay?
Yes, sir.
Suppose this is the old question that came in the exam. In an every 70 kg adult male, what is the distribution of the body water?
No, sir.
Okay,
I
we
can't
will
see
come
that.
back to this question. Okay, 70. Okay, 70 kg adult male. Remember, there is 42 liter of the total body water,
Okay, sir.
and this is distributed between the intracellular and the extracellular component. So 2/3 or 28 liter of the total body water exists in the intracellular compartment. The other 1/3 or 14 liter of the total body water is in the extracellular compartment.
Yes, sir.
Okay, just remember this. Now, uh, what is the composition of the Hartmann solution?
Okay, so there is a sodium chloride, bicarbonate, lactate, and glucose.
Very good.
Not.
Okay, very good, very good. Okay, just remember the composition. Okay, the sodium is 131 millimole per liter, chloride is 111 millimole per liter, potassium is 5 millimole per liter, and calcium is 2 millimole per liter. Bicarbonate is 29 millimole per liter. Okay, they asked me this
Yes.
question in the in the station of uh, this was
Clear.
I think the this was the not the hypocalcemia station. Um, yeah, in the hypocalcemia station, okay, like how the
Okay.
vitamin
Okay.
D3 is formed and all those things. So they asked me this question as well. Now, what is the normal saline made up of?
Sodium and chloride ions.
Can you tell me the concentration of the sodium and chloride in normal saline?
It is 154 sodium and 130. I
Yeah,
can't remember.
154 millimole per liter of the sodium and same 154 millimole of the per liter of the
Chloride.
chloride. What is the difference between crystallite and colloid, and what are the advantages of one over the other?
Okay. Uh, so crystalloid it contains the electrolytes and metabolites, whereas in colloids it contains the protein. So there is a massive increase in intravascular volume while using the colloids, and it also leads to third space loss in if later in the later stage, but it doesn't occur in crystalloids. Also,
Okay,
there will
so
be protein hemodylation in case of colloids.
okay, so you can mention these things as well. Now, crystallites are solution of water soluble molecules. Colloids are fluid which contain large insoluble molecule like gelatin. Correct? Crystallites are
Yes,
cheap
sir.
and have none of the side effects. Colloids are like can cause the anaphylactic reaction. Okay, and coagulopathies. Remember this.
Yes, sir.
Now, colloids provide comparatively more intravascular expansion, but this effect is lost after several hours. Okay,
Yes, sir.
so these are some of the now. Tell me about the. Okay, we will ask some new questions as well here. Okay, uh,
Okay, sir.
you drop some question. Okay, so
Yes.
Why would you give fluid challenge rather than speeding up the drip? Now the answer for this, Dr. Prabhat, remember, okay? Because the fluid
Yes, sir.
challenge is both diagnostic and therapeutic.
Okay.
And going fluid challenge slowly does not stretch the left ventricle as explained by the Starling law. Now, speeding up the drip does not give information regarding the patient's cardiovascular response, and
Yes,
it may
sir.
not resuscitate the patient quickly, okay? So they will ask after this question, can you tell me about the Frank Starling law?
Yes, sir.
So that's why I ask you the Frank Starling law, okay? Now, uh, you actually yeah, we discussed this about this counter current multiplier mechanism. Remember, okay, the descending limb of
Yes,
the
sir.
loop of Henle is permeable to water but impermeable to solutes. Thus, the water
Yes, sir.
molecules will move from the tubular wall into the medullary space, making the filtrate hypertonic. This is the point number one. The point number two, the sodium is actively transported out of the thick ascending limb of the loop of Henle, which is impermeable to water. Now, this will create an osmotic pressure, drawing the water from the descending limb into the hyperosmolar medullary space, making the infiltrate more hypertonic.
Yes, sir.
Remember,
So
that's
there will be
how. Yeah,
active
yeah.
transport of fluid from the urine to the interstitial blood
Yeah, this
vessel.
simple. The descending limb of the loop of Henle is permeable to water, and the
Okay.
ascending limb of the loop of Henle is impermeable to water. So from one side, the water is like extracting from the tubular fluid, making the tubular fluid more hypertonic. From another side, the water is again moving into the medullary interstitium. So this that's
Yes.
how from one side the water is moving out of the tubular fluid. From another side, the water is moving into the tubular fluid. Like
Into the.
this is how the water is extracting from the tubular fluid. Remember that
Yes, sir.
the counter current multiplier, okay? So
Okay, sir.
now the new question here, what is the option to monitor the fluid balance? Like Dr.
Monitored.
Prabhat, how will you clinically monitor the fluid balance of the patient?
Okay. Yes, I will check the patient cardiac index if is the tachycardia is settled or not, if the pressure has become normal or not, and output is more than 1 liter per day or not.
Okay, you'll check the cardiac index, which include the heart rate, blood pressure, capillary refill time. Okay, you'll also check the urine
Yes, sir.
output of the patient. You will check the central venous line pressure, and you will check the pulse oximeter, and you will go for
Pulse
chest
oximeter.
X-ray if required. Okay, remember these
Yes,
things.
sir.
Now, what are the conditions that require increased maintenance fluid? So this include,
If
yeah, go
yeah,
ahead.
if there is ongoing bleeding or ongoing loss of fluid, and if it is ongoing third space loss.
Very good, very good. Okay, like vomiting, fistula, pancreatitis.
Vomiting.
Okay, hemorrhage, IES. Now, factor determines how much fluid the patient is needed.
Um, I don't know, sir.
Okay, so the pre-existing fluid deficit, the ongoing losses, the weight, the metabolic requirement. Okay. Now, what are the fluid good for maintenance?
So NS and ringolactate, and
Yes,
also dextrose
yes,
also.
yes, yes. The crystalloid, normal saline, or the Hartmann solution. Now, what is the
Yes.
basic basal water requirement for an adult?
6 6 liter per day.
Okay, 30 to 40 ml per kg per day. Remember, okay.
Okay.
Yeah, that's it. We discussed the whole station of this fluid management. Now, what is the purpose
Yes,
of the
sir.
fluid therapy? Remember, okay? What is the purpose of the
Yes.
fluid therapy? Now, the purpose of the fluid therapy is to satisfy the basal requirement of water and electrolyte to replace the electrolytes and fluid losses and to support the arterial pressure, okay, in case of shock.
Yes, sir.
Yeah, just remember these. Now,